Okay, let's jump right into this explainer. Today, we're doing some serious clinical detective work. We're mapping out the peripheral nervous system, specifically diving into the incredibly dense but absolutely crucial clinical masterclass that is Chapter 457 on peripheral neuropathy. We're going to break down exactly how a master clinician thinks when they're faced with nerve damage. Here's our agenda for today. 1. The clinical approach. 2. Pattern recognition. 3. Electrodiagnostic studies. 4. Hereditary neuropathies and canvas. 5. Diabetic and metabolic causes. And 6. Toxic and nutritional neuropathies. Let's get into it. So, how exactly do we solve this clinical mystery? How does a neurologist deduce the exact origin of a patient's neuropathy when there's a literal ocean of possibilities out there? With hundreds of potential causes, from genetic mutations all the way to toxic vitamin overdoses, you can't just guess. You absolutely need a rigorous, systematic method. And here is our anatomical scene of the crime. As you know, the peripheral nervous system isn't just one simple wire. It's this massive, complex web of roots, trunks, divisions, cords, and terminal branches. And a lesion anywhere along this pathway, well, it completely changes the clinical presentation. Section 1. The clinical approach. The real trick here is that you've got to rapidly cycle through these 7 key questions to narrow down your usual suspects. First up, what systems are involved? Are we talking motor, sensory, autonomic, or maybe a mix? Second, what's the weakness distribution? Proximal versus distal, or symmetric versus asymmetric? Third, what about the sensory semiology? Is it small fiber pain and temp loss, or large fiber proprioception loss? Fourth, is there upper motor neuron co-involvement? Fifth, the temporal evolution, acute, subacute, or chronic? 6, any hereditary clues like high arches? And finally, what are the systemic medical comorbidities? Master these 7 questions, and trust me, the fog really starts to lift.
Section 2. Pattern recognition.
Now, by synthesizing the answers to those 7 questions, we can anchor our findings into 10 core patterns. This instantly separates disease categories. So, for example, if your patient has symmetric, proximal, and distal weakness, that points squarely to pattern 1, which is highly suggestive of inflammatory demyelinating polyneuropathies, like GBS or CIDP. On the flip side, if you're seeing an asymmetric proprioceptive loss without weakness, you're looking at pattern 9. That directs us straight towards sensory neuropathies or ganglionopathies, maybe paraneoplastic in origin. Recognizing the pattern is literally what separates a targeted workup from a massively costly fishing expedition. Section 3. Electrodiagnostic studies. All right, let's take our investigation into the forensic lab. We have to contrast primary axonal damage against segmental demyelination. So axonal degeneration gives you reduced wave amplitudes but relatively preserved conduction velocities. But with segmental demyelination, you're seeing prolonged latencies, marked conduction slowing, and temporal dispersion. And here is what's absolutely vital. You have to distinguish between uniform and non-uniform slowing. Uniform slowing points to a hereditary condition like Charcot-Marie-Tooth type 1, but non-uniform slowing with conduction block, that points heavily to acquired conditions, again like GBS or CIDP. And that means you might just have a highly treatable disease on your hands. Section 4. Hereditary neuropathies and canvas. Let's break down Charcot-Marie-Tooth and HNPP by looking at the exact protein disruptions. Notice how CMT1A is caused by a PMP22 duplication, whereas CMT1B is linked to MPZ mutations. Then we've got the axonal CMT2, prominently featuring CMT2A2, which is driven by MFN2 mutations that actually disrupt mitochondrial fusion kinetics. We can't forget CMTX1, with its connexin 32 mutation and that classic intermediate conduction slowing. And it's so interesting to contrast this. While CMT1A is a duplication of PMT22, HNPP is a deletion of that exact same gene, and that presents clinically as pressure-related transient nerve palsies. We've also got to define some highly specific hereditary metabolic entities. Take SORD neuropathy, which has recently been recognized as the most common recessive axonal neuropathy. It's caused by biallelic sorbitol dehydrogenase mutations, and that leads to this massive, toxic accumulation of sorbitol. Then we have Fabry's disease. This is an X-linked disorder marked by alpha-galactosidase deficiency. It leads to lipid accumulation in vessels and nerves and often presents with agonizing, burning pain in the extremities, plus those characteristic reddish-purple angiokeratomas. Now, a super fascinating genetic suspect is canvas syndrome. It's caused by biallelic RFC1 intronic repeat expansions, and you can definitively spot it if you look for a very specific triad. The combination of sensory neuropathy, cerebellar ataxia, and bilateral vestibular areflexia, conjoined with a chronic dry cough, is your definitive clue. It's a really spectacular example of how doing a very specific systems check can diagnose a rare genetic disorder.
Section 5. Diabetic and metabolic causes. Metabolic disruptions offer some really distinct clinical markers. Peripheral neuropathy, specifically acute intermittent, hereditary coproporphyria, and variegate porphyria can actually mimic GBS. It's triggered by P450-inducing drugs, diets, or hormones, and it presents with acute abdominal pain and psychosis. But the crazy part? It's uniquely treatable with glucose, hematin, or the siRNA givosiran. We also see ALD and AMN driven by peroxisomal transporter ABC1 mutations. And then there's Refsum's disease, caused by PA-ISEC-H mutations that lead to phytanic acid accumulation. That presents with ataxia, ichthyosis, and retinitis pigmentosa, and is treated with dietary restriction.
Now, we have to talk about diabetes. Diabetic nerve damage isn't just one disease. It is a wide clinical spectrum. It's by far the most common cause of neuropathy in the developed world, but it really doesn't just present in one uniform way. So beyond the classic creeping stocking glove sensory loss of DSPN, we see rarer syndromes like Bruns-Garland. This diabetic lumbosacral radiculoplexus neuropathy presents with sudden, exquisitely painful asymmetric proximal thigh wasting and severe weight loss. We also see specific mononeuropathies, most famously including pupil-sparing third nerve palsies. Section 6. Toxic and nutritional neuropathies. Sometimes the call is coming from the patient's own medicine cabinet or even their diet. It's absolutely crucial to understand how life-saving chemo agents like vincristine, taxanes, and cisplatin, or NRT mitochondrial toxicity and HIV treatment can cause severe nerve damage. But get this, even an over-the-counter vitamin B6 or pyridoxine overdose can selectively destroy sensory pathways. High doses of B6 can lead to a pure sensory ataxia and ganglionopathy. It perfectly illustrates exactly why a thorough medication history is just non-negotiable. Nutritional deficits also offer some surprising clinical mirrors. Thiamine, or B1 deficiency, presents as dry beriberi with neuropathy or wet beriberi with cardiac failure. But let's contrast this with copper deficiency. Copper deficiency creates a myeloneuropathy that clinically mirrors B12 deficiency, complete with microcytic anemia and neutropenia. And here is a wild fact. Excessive zinc intake can actually induce this copper deficiency. There are documented cases where patients were using massive amounts of denture fixatives containing zinc, and it completely depleted their copper levels. We're going to end on a somewhat provocative thought about the limits of modern medicine. Despite this massive, exhaustive diagnostic framework we just walked through, what happens when every single test comes back perfectly normal? Well, we arrive at cryptogenic sensory polyneuropathy, or CSPN. Up to 50% of the time, despite our absolute best efforts, we end up with this diagnosis of exclusion. The good news? It generally has a very slow, benign progression. But it leaves us with a lingering question. What invisible mechanisms are we still missing in the vast network of the peripheral nervous system? Now that is a mystery waiting for the next generation of neurologists to solve.